All right, we'll go ahead and get started. Thank you for joining. So today we'll be talking about opportunities and lessons learned from global medicine and for the diagnosis and treatment of HLH. This has been hosted by the HS Steering Committee, specifically the HS Global Working Group that just formed in the last couple of years under the steering committee. Here we go. All right, I'm supposed to give you an introduction about the Histiocyte Society. It is a nonprofit group of over 250 physicians and scientists from around the world. And it is a group committed to advancing the knowledge and improving outcomes with patients with histiocytic disorders, including LCH, rare histiocytic disorders, and HLH. And it has a focus on both clinical and basic research and education for histiocytic disorders. So all participants are muted in the Zoom webinar. If you have any comments, please submit those via the chat in your webinar panel. And I have both of those open and we'll be checking them regularly. The part of this session is actually as a panel. And so it would be really great if people did put in questions or comments in the chat that we can keep the conversation going. So the chat will be in the controls at the bottom of your screen. After clicking, the chat window will appear on the right. Type your message and press enter to send it. So just click this button and then it'll come up for you to be able to send your comment. I also have the Q&A up, so if you happen to use the Q&A, which is this button over here, that is also fine. The Q&A, she's telling you now. So this questions for the speakers can go in the Q&A box. Put questions for the staff in the chat box because not everybody can see that. And like a question in the Q&A box, if your question has already been asked by somebody else, and it'll kind of push it up to the top. Due to time constraints, we may not be able to get to all questions. If you like what the Histiocyte Society is doing, we do encourage you to become a member. And there's the link if you want to join membership. If you are a histiocytosis expert and you want to be able to be found, please sign up as one of our Histiocytosis Association physician directories so that people can find you. Okay, so it was supposed to say today's speakers, but really Michelle and I are here just as moderators. So Michelle Hermiston used to be at UCSF. She is a pediatric hemonc physician who is now the dean of the medical at the health center at Vinh Uni in Vietnam. And then I am here. I'm Melissa Hines. I'm an ICU physician at St. Jude Children's Research Hospital. And we will be hopefully helping along the conversation. We have so far only a couple of our panelists have joined. Oh, Carlos is here now. Yay! So we have an interesting group of panelists. We have a group from Asia. Dr. Cook is from Vietnam in Ho Chi Minh City, and she's a pediatric hematologist. And then from Latin America, right now we have Carlos Alberto Pardo González. He's a pediatric hematologist from Colombia. And then Jorge Luis Buitrago, who is also a pediatric hematologist, oncologist from Colombia. So we have a nice broad group, I hope. Remember to complete the session survey to make sure that we get feedback on this event so that we know if we should be doing something like this again. Also, one last housekeeping thing, our Histiocyte Society meeting this year will be in Rotterdam, September 27th through 29th, 2026. Scott and I have been working hard on coming up with good things to be happening in Rotterdam about HLH, and it looks pretty good to me. So please register. It is you can join virtually or in person. All right, with that, I am going to stop sharing and let Michelle share her slides. Let me see, can I cancel sharing?
Can you see those okay?
Yes.
Great. So
Yeah.
I first want to thank Melissa and Scott and the Global Working Group for giving space to this. I was asked to speak a little bit about what I've learned living in two settings and thinking about patients with HLH and other hyperinflammatory disorders. And I think that what we're really going to learn tonight comes from our panelists. I'm going to keep this very short, but just hope to set the stage of the issues we need to think about. So I think, globally, most of what we know about histiocytoses comes from high income settings. I think it's important for us to remember, though, that children do not choose where they are born in this world. And 80% of children actually live in low and middle income countries that have varied resources and more resource constraints than certainly I was used to practicing medicine in the US. And most of our published literature and studies on HLH really emerge from these high income settings. This is a map of accessibility to transplant. And I think, as everyone in this audience is probably aware, the only cure for primary inherited HLH is a transplant. And so there's a number of kids in the world where has very low or no accessibility. And so important to think about that and how do we manage these children in these contexts. And I think one of the things that has been a really pleasant and helpful surprise for me is that our relationships and our partnerships with colleagues around the globe are bidirectional. And I have to say that in learning from Dr. Cook, who was one of our first fellows in our fellowship training program in Vietnam, I completely changed how I think about and manage these kids. So hopefully there will be some lessons learned from how do people take care of these patients in a setting where they may not have access to the things that we normally do in high income settings. And so I think the way that I'd like to structure this is to think about how do we approach a patient with hyperinflammation or suspected HLH. And this is from the SOP that we used at UCSF that was developed by Will Temple and Ben Wong and myself, and really starts with recognizing hyperinflammation, identifying and treating the trigger, calming the hyperinflammation, determining if there's an underlying defect in the immune system, and then replacing that immune system if indicated. And what I thought I would do before we open it up to our esteemed panelists is just to think about those things from the viewpoint of having been in hospitals in both a high income and a low income setting. So there are many different panels for diagnostic criteria for HLH. I'm not going to go through these for this talk, other than just say that to remind us that these were initially in 94 and 2004 developed as inclusion criteria for clinical trial. And I think one of the things that I've learned from a resource constrained setting is that following these, obtaining these is not always easy. Trending them, which is the approach we usually used at UCSF, can be prohibitively expensive, or the turnaround time can be really hard or long. And so thinking about that is important. And I think it's important to remember that these aren't necessarily a checklist, but really guidelines in terms of how to think about and when to intervene with a patient that might have hyperinflammation. I also think it's helpful to remember that these guidelines that we use to diagnose HLH really are sequelae of a cytokine storm. And I think one of the things that I learned from my colleagues in Vietnam in particular, is that they were very attuned to these and intervened when things seemed to be going in the wrong direction. And I hope we can have a conversation around that tonight. But if we think about fever, that is driven by cytokines. Pancytopenia can be hemophagocytosis, but early is probably more likely a cytokine-mediated effect. High triglycerides come from TNF alpha. Hypofibrinogen is from hyperfibrinolysis, which is driven by activated macrophages. Elevated soluble IL-2 is a really helpful marker, but is not available in many places around the world. And so you really have to use your clinical acumen to, I think, diagnose these patients. I think the second thing is thinking about the trigger And one of the things that I've learned in Vietnam is that people are very aggressive for looking for that and for thinking about that. I think it's helpful for all of us to remember that if we look at the animal models of HLH, you have to give them a trigger. It doesn't normally occur spontaneously. And every time a patient has a flare, you need to think about a new trigger, even if you check the viruses the day before. And so, I think being aggressive about the trigger and treating that is really important, especially in resource constrained settings. Calming the hyperinflammation is, and watching how people do this, at least in Asia, where I have the most experience, has been probably the most important learning lesson. I normally think about HLH as two phases. You have induction therapy to gain control of the damaging immune hyperactivation, treat the underlying infectious triggers, limit organ damage and mortality. And then definitive therapy, if indicated, to prevent future events by correcting the immune defect with a transplant. This is still the published standard of care based on really HLH 94 and also 2004 therapy, and we followed this. And I think the next important lesson that I've learned in the resource constrained setting is that this isn't an oncologic diagnosis to look at and to treat the patient. And in a setting where antimicrobial resistance is high, where patients can get very ill very quickly if they are immunosuppressed, to think about withdrawing therapy more quickly. And so probably the biggest lesson is that I have learned in the setting I am now is that treating the patients, some patients do well with steroids alone. Many patients will not need 8 weeks of etoposide, and some patients are going to need more than that. And so really tailoring to the patient and their level of inflammation in front of you, I think is the most important lesson I've learned in this context. We all know that standard therapy does not cure every patient. And we have lots of fancy things that we can use, almost none of which are actually available in a resource varied setting. And so that may be an interesting conversation to have in a bit about how do you approach these patients when there's not the fancy options we're used to. The fourth step, really thinking about an underlying defect in the immune system. And I would argue that defining this, if you don't have transplant, may not be the best uses of your resources. We often would do flow cytometry screening because it was fast. You get a hint and then do confirmatory genetic testing. But in many settings around the world, these things are not available to do or take significant time, or the family has to pay. And may have to make a choice between making a diagnosis of a genetic mutation that you may or may not have cure for versus eating and transportation. And then I think finally replacing the immune system if indicated. And just, I started with this slide, but just to remember that this is not accessible everywhere in the world. And so I think an interesting thing to think about is how do we do palliative management of HLH if you don't have access to transplant? These are my personal biases from what I've learned in the context here, but I think having a conversation with the family and directing the goals on living as well as you can for as long as you can is important. Recognizing getting hyperinflammation under control as quickly as possible is critical. You can do that with a few screening labs and looking at the patient. The practice here is often antibiotics, but stopping as soon as cultures are negative to minimize antimicrobial resistance. And if you have a controlled setting, watchful waiting is also acceptable because I think it's the antimicrobial resistance that can be a real problem in these patients, even if you have access to therapy. It's much harder to transplant a patient who's resistant to most antimicrobials. Many people will use steroids alone or steroids plus ruxolitinib in this setting. It's very inexpensive. It works really well. And then they wean as quickly as possible using the clinical status as a guide instead of being very rigorous to follow a protocol. And you repeat that as needed. And then finally, I think avoiding triggers we can, like live vaccines, but encouraging inactive vaccines to decrease the number of triggers that you may have to deal with is important. So I'm going to stop there and then hand it over to Melissa to lead the questions and Q&A with our panelists, and hope that we can all learn from the challenges they face in their respective settings, but also some different ways that we might be able to think about our patients with these diseases. All yours, Melissa.
Thank you. Hang on just a second. All right. So moving on to the panel discussion, I hope everybody will be lively on the panel. So to Michelle's point, so this is actually looking at a map of a systematic review of the literature, looking at studies about HLH that were published in LMICs. And you can see that there's kind of a limited amount of studies that are actually coming from low middle income countries. And so the countries with data are in green. And so this represents maybe 15% of LMICs. And so what I'm trying to say is we need to publish data from these areas so that we understand what's going on with HLH. Our panelists, we have panelists from both Latin America and Asia. I've already introduced them, so I'm not going to belabor it. Who's here? So we'll start with Dr. Cook. Just tell us a little bit about the HLH that you typically see in Vietnam in your setting. So what are the most common triggers or predispositions that you see, and how many HLH patients do you see in a year? And we'll just go down the list.
Can I share some slide? I would like to talk about the situations of the HLS in Children's Hospital number 1, and I prepare some short slide in our hospital. Can I share some slide?
Absolutely. Let me stop sharing. There you go.
Okay. Okay. I cannot share in the hospital. Children can share from my computer.
Maybe you can email them to me, Dr. Cook, and then I can see if I can share them and we can move on to one of the other panelists in the meantime.
Okay.
Yeah.
Or you could WhatsApp it to me. I could pull it off from that. That might be easier.
All right, Jorge. The question was, what is the most common trigger you typically see in your hospital, and how many HLH patients are you seeing?
Okay. In our hospital, we have 130 beds in my department, and we have from 50 to 80 patients of the HLS, and maybe 15 new cases of the LCS in our hospital. And we also have the transplant units, but just from 2025. From the last year, and we don't have any case of the transplant of HLS. And in our hospital, we have the the trigger of the HLH in a hospital almost from the infection, because in the tropical country we have a lot of patients with infections, and especially the EBV and CMV and dengue fever. We have 60% of the patient of SLF involved to the EBV infection. And also in our hospital, we also have the immunodeficiency, a lot of case with pediatric immunodeficiency. And in our hospital, I think the biggest factors in our practice that improve outcomes of patients with HLH is the early diagnosis, find and treat trigger earlier if needed. And a lot of patients have many triggers in the same time. For example, in our hospital, maybe SLS patient has the trigger of the EBV and infection, bacterial infection, or fungus infection in the same time. And the laboratory tests in our hospital have lack of we have lack of laboratory tests, for example, the interleukin panels or the flow cytometries or genetics tests. In our hospital, genetics tests and flow cytometries are not covered by insurance, and we have to transfer the sample test to other center to do the flow cytometry and genetic test. And in our hospital, we also lack of drugs. For example, the ruxolitinib and rituximab are not covered by the insurance, and they are very expensive. Yes, and maybe the challenge for the SLH diagnosis in our hospital is for example, the ABV in the T or B cell, the flow cytometries and genetic tests. And we try to diagnose it with the laboratory test based on the criteria of the HLH 2004 protocol, and try to find the triggers. And we usually do try to find the infection first. For example, the bacteria, virus, HIV, EBV, CMV, fungus, and immunodeficiency. We also have the test of the IgG, IgA, IgM, and flow cytometry BT and case, but other tests to confirm the primary HLH is limited in our hospital. For example, we lack of the flow cytometry to do the protein functions, such as the CD100 and 107A, and the CF protein or something like that. We cannot do the flow cytometry to confirm the protein functions. And about the drugs, in our hospital, we lack of a lot of drugs of the anti-interleukin drugs. For example, the anti-interleukin 18 or interferon gamma, anti-interferon gammas are lack of in our hospital. But we from the last year, we have the ruxolitinib in our hospital, so we can use the ruxolitinib for the SLS patient, but it is expensive and not covered by the insurance. About the treatment in our hospital, we usually offer treatment of the dexamethasone to calm down the hyperinflammation, and we usually follow 2 or 3 days. After that, we follow the clinical symptoms and laboratory tests to confirm that the conditions of the patients were more severe or not. And after that, maybe we can add the etoposide or rituximab for this patient if the laboratory tests were severe. And about the PID, we also find the rib disease, such as the PID. If the patients had a lack of IgG, we can add the IgG supplement for patients in our hospital. So in Children's Hospital number 1, now we can do the genetic test, but it's not covered by insurance. And we also find the family HLH and PID with the genetic mutation. So we also see the family SLH such as the UNC 13D or STBX2 is linked lymphoprophylaxis, cardiac legacy, and recently syndrome type 2, and PID which is linked with CVID with Cas11 mutation. We also see these kinds of patients. And in Children's Hospital 1 in Vietnam, we also, like Dr. Michelle said, we also find the triggers and try to treat the triggers. And dexamethasone is reference of the treatment in our hospital. And we also have the supportive care with the IVIG blood transfusion and at immunosuppression such as etoposide or rituximab now. And so we are a referral center. So we receive many patients with the SLS from other hospitals. And some tests we can do in our hospital. And also we cannot transplant for the SOS patient, but we follow the situations of the patient and add dexamethasone, use the rest of immunosuppressions for every time they have the trigger to make the flare of the SOS. So that is the conditions of Children's Hospital number 1. Yeah.
Thank you. I think you went through all my questions. Thank you, Dr. Cook. That was amazing. I'll review some of your answers here in a second whenever I also ask Jorge and Carlos and ask you some more specific questions. Jorge, so the question we started with was, let me see, what did I start with? Share. There we go. Was what are the most common triggers that you see and how many HLH patients are you usually seeing a year in your setting?
Okay, thank you. We have both realities because we are a four-level center. We have a bone marrow unit. So we have some patients that are referred to receive the bone marrow transplant that are primary. But also we are located in a tropical zone. So we have a lot of dengue fever infection. The last year we had 2 patients with HLH related to dengue. So that was really interesting to have both kind of patients.
Thank you. Carlos, can you answer the question if you're able?
Yes, thank
Hi,
you.
Carlos.
My
Carlos, we're having some connectivity issues.
the different pathologies for tigers, but the important is spike. But dengue is not more important, but I
Carlos, maybe try turning off your video again because we're having some connectivity issues with you. Carlos, we will come back to you here in a second. All right. There, I see Carlos. You want to try again? Let's see if it works better this time.
Yes. Okay. Okay. I'm sorry for my internet is not the most adequate, but I think the infections, the viral infections, are the most important etiology. Um, my experience in our hospital is Bogota. Bogota is a far away the coast. Um, this is characteristic tropical difference. For example, my college in Cali. Um, I think is the most important difference in etiologies with my college. But the infection is the most important too.
The infection, EBV, CMV, dengue.
Yes,
Yep.
yes. The viral infection is the most important in our etiologies.
So Dr. Cook has alluded to this, and I wanted to ask her a little bit more about what you think has improved outcomes in your patient setting whenever you started treating these patients. I had a specific question for Dr. Cook. I know that you said that it's hard to get ruxolitinib and it's quite expensive, but having access to that drug, has that been helpful in patients where you felt like you didn't want to quite give etoposide?
To improve the outcome of the HLS, we think we had to find the triggers and the root disease of
Right.
the patient. Yeah, such as in Vietnam we have the bacterial infections, and the EBV. The EBV infections is the most common in our hospital. It's the maybe EBV infection evaluated to the SLS 60% in our hospital. And so we usually start the dexamethasone, and from 2025 we have rituximab, and we usually start with the rituximab. If the patient can pay
Right.
if the patient cannot pay the rituximab, we will use the etoposide for this patient. Yes, because the etoposide and cyclosporins are covered by infection, by insurance. Yeah, and we try to treat the infections, bacterial infection. For example, the more antibiotics. We also have a lot of antibiotics in Vietnam to treat the bacterial infection and fungus of antivirus or antifungus for patients. And we also have the PID, a lot of patients with the immunodeficiency. Yes, for example, for the patient infection with CVID, we can use the IVIG. Yeah, we can use the IVIG or anti-virus, antibacterial, antifungus for this group. Yeah.
There was a question about what are the common concerns for giving etoposide versus ruxolitinib? It sounds like your biggest concern about giving etoposide is increased risk of infection. Is that right?
Yes.
Compared to
Maybe
ruxo? Yeah.
depend on the situations of the patient. Yeah. So because the etoposide, we have to use the infusion, and it has a lot of side effects of side effects of the etoposide. But rituximab, I think, is more useful for patient because it's just use oral, orals by oral,
medication.
and And until now, we feel that is effective for the EBV infection involved to the HLH, but maybe long outcome. We will follow the long outcome.
I think the big things there are etoposide requires typically central access, but can be given in different ways, but also ruxolitinib is available orally. So the biggest difference is, as far as my experience with either drug, is that ruxolitinib also is, so if you have a patient that can't tolerate by mouth, so a really, really critically ill patient, the question always comes up, can they actually absorb the medication? So in a critically ill patient, maybe etoposide, depending on how sick they are, may be a better choice. But it's still hard to know when you do which one. Jorge, what are the biggest factors in your practice that you think have improved outcomes as far as diagnosis and treatment in your patient population?
Thank you. I think that are two things. The first one is the early clinical suspicion. Like Michelle says, that is very important to work with the pediatric intensive care unit team, because that patient need to have a very, very high index of clinical suspicion to make the diagnosis early and can give to him the appropriate treatment. And the second thing that I think that clear to change the prognosis is the access to bone marrow transplant, because when it's a primary patient, in one HLH primary, you have to have access to bone marrow transplant early. In other words, the patient's gonna die and it's so painful. So I think that both things are the most critical in our institution to improve the prognosis.
Absolutely. Carlos, do you have anything you want to say about biggest factors that you think have improved diagnosis and treatment in your hospital of HLH?
Yes, I think the prognostic is closely to the suspicion. I think the is the most important. The first symptoms, febrile state, and moderate symptoms is the most important in the first step in diagnosis. The suspicion is the most important for me and for our group. Um, the, the second question on the etoposide is the most important experience our group, because ruxolitinib is um, no authority in my country for this pathology. And then our experience with this drug is not necessary for the first step in the treatment for our patient. But I think the experience with HLH protocol is very important for our, because I think is adequate for the management in our experience. Etoposide, I think, plus dexamethasone is adequate for prognosis our patient. But ruxolitinib, I think, is important for second strategy for treatment our patients. But it's difficult to have this measurement for our.
So you still are a big etoposide believer, which I agree. I think etoposide is still a fantastic drug and is very, very effective. So the next thing I wanted to ask people about is, so there are a lot of challenges with HLH diagnosis. And it sounds like in Vietnam, they've been able to develop some of the in-house testing, at least for determining CD107A mobilization, perforin expression, availability, and genetic testing is sometimes available. But how is this working in the setting of in Colombia as far as, are you able to make the diagnosis pretty easily for familial or underlying genetic defects that pushes you to transplant? And do you have any limitations to just the general diagnosis of HLH as far as availability of testing? And how does this change how you approach patients, if at all? Jorge, I open it to you.
Okay, thank you. No, actually, in Colombia, we can ask for every test, but most of them are in-house. So in our hospital, we have the basic markers to make the biggest or stronger diagnosis of HLH, but the fancy test, functional, genetic test, it isn't available in-house. So we have to refer that test to out of the country, or maybe some of them in other cities of the country may do some of that in cytometry or maybe functional test. So the time to wait to the answer of that test, the results are around 6 to 8 weeks. So most of the patient, we have to start the treatment before had that kind of test. So for transplant, actually, that are my specialty in this moment, we have to start to work to try to control the first step, the hyperinflammation phase in the patient, and try to wait 6 to 8 weeks that have that result to know if it's a primary or in other words, is a secondary HLH, to try to define if the patient needs or not the bone marrow transplant, if we have any doubt in the clinical case at the beginning.
To be fair, whenever it comes to genetic testing in high income settings, it also takes about, I mean, maybe we can get it at 4 to 6 weeks instead. But so it is still a pretty significant delay, even in a different setting. But I guess my question is, if you know that you're going to have that delay, do you go ahead and send HLA testing to start seeing if so you can find a match for a transplant if you're highly suspicious? How do you deal with that delay to kind of get a patient to transplant?
We start to work to try to find the best match since the beginning. When we have the big suspicion, we just start to try to find the best match for the patient. We don't have to wait until we confirm it. No, we don't have to wait.
Awesome. And let me see. I feel like I have another discussion point coming up. So I think one of the things I wanted to bring up with this particular discussion point was I wanted to ask Dr. Cook's experience about de-escalation of therapy, and not necessarily following the HLH 94 2004 protocol. So how do you make decisions about de-escalation of therapy? Because as mentioned already by Michelle and Dr. Hermiston and Dr. Cook, a lot of times one of the biggest issues we have is actually infection, and controlling of infection, especially if you especially in the patient population that they're talking about. So Dr. Cook, how have you changed your practice at all about de-escalation of therapy? So how do you decide that you're not going to give all 11 doses of etoposide per the HLH 94 and 2004 protocol?
Because in Vietnam, we usually have the neutropenia, neutropenia in HLH patient, and we don't have the special room for this patient. We have a lot of patients because in our hospital, we have patients with benign hematology disease. So if the patient had a severe neutropenia, we had to decrease the dose of etoposide, maybe just from 25 to 50% etoposide for patient. But after 2 or 3 days, we evaluate the conditions of the SOS patient. If they can tolerate with this dose, we can add one dose for patient to make sure that they don't have the very high risk factor of the infection more. So this and in our hospital in SOS patient with this dose of the etoposide, we feel that they can tolerate more than we use on dose of the etoposide. Yeah.
So usually what will happen is if you'll follow the ANC, and if it seems like they've kind of recovered and now their ANC is going back down, the neutrophil count is going back down, you'll actually dose reduce the etoposide and still give it if the patient needs it.
Maybe depend on the laboratory test too, especially the ferritin and the CBC, the transaminase, then AST, ALT, and we decide to the dose of the etoposide. On most institution, we have to reduce the dose of the etoposide. Depend on the neutropenia and depend on the transaminase, the ST and ALT bilirubin. We have to reduce the dose of the etoposide.
Yeah. So you make the decision to reduce the dose based on toxicity, pretty much. If you feel like they're having some toxicity from the etoposide. Do you ever reduce or eliminate etoposide if you feel like their disease is under control before the 8 weeks is up?
Yes, if the patient just have the evaluated of the transamina, for example, they have the over 1,000 units of the AST and ALT, we usually reduce the half dose of the etoposide.
Okay.
Yeah.
For liver dysfunction. Good to know. Jorge, what is your most common approach to HLH treatment?
We are more conservative way. We are more like the HLH 2004. So we start with dexamethasone and etopose. And when we are seeing the biomarkers, ferritin, and clinical improve of the patient, we space the etopose doses and like the protocol. We use like the protocol, and we have a lot of experience with ruxolitinib, just one patient. I used that in one patient that was HLS after bone marrow transplant, and I could use it because the patient had a bone marrow transplant. So in Colombia, it's approved for that cases. The use of ruxolitinib related to bone marrow transplant. So that's why I could use that medication in that patient, but was really tricky for me because the ruxolitinib have some side effects like thrombocytopenia, leukopenia. So it's a little tricky to use because it is easy to make the differentiation if you have a reactivation of the HLH, or maybe it's a side effect of ruxolitinib. So it's a little tricky. So we use the strategy of HLH 2004 and more like the protocol, try to go down slowly, and only one patient with ruxolitinib.
But do you combine the etoposide and the rituximab in the same time, or you wait for a little time to add the rituximab?
For that patient, we use the ruxolitinib for the maintenance for this last phase. When we finish the toposol, after that, we start ruxolitinib.
Okay. Because in this time we use the rituximab first for some patient. For some patient, if they have the very severe neutropenia or evaluated transamina, and we see that the symptoms of the patients is recover a little compared to to use the etoposide.
So you'll use the Ruxo if you have a patient that's
Yeah.
very neutropenic to
Yes,
start with.
especially the EBV.
The EBV.
Infections, yeah, evaluate related to the SLS.
And have you ever used
easier.
Ruxo with etoposide? Them at the same time? Ruxo and etoposide together?
No, rituximab, just rituximab first.
Okay. And
Yeah,
then you'll transition to etoposide if they need it and stop the Ruxo?
yeah.
Good to know. The last thing, we have about 7 minutes to talk, and so please put your questions if you have any that you want to ask our panelists. But one of the things that came up that I thought was really interesting is this question of, and so Jorge, you have a transplant, but maybe not everybody can get transplanted. What do you do with patients that have primary or familial HLH that you can't transplant? How do you palliate them? And you alluded to this a little bit, Dr. Cook, that you will, as the patient reactivates, you will give them short amounts. You'll look for the trigger again, and then you'll give short amounts of steroids or a couple doses of etoposide. But what is that? And you'll follow their ferritin over time. But what does that look like as far as, do you bring them frequently to clinic? How do you follow them?
In our hospital, we usually follow the patient every month, from 1 month to 2 months, to check the laboratory test for this patient. And if the patients have any symptom, especially the fever, they have to come to our hospital earlier. And about the dose of the dexamethasone, because they usually have the reactive SLS, the flare reactive SLS, sometimes has the severe flare, and we will use the dexamethasone upfront. Depend on the situation, we use the half dose or full dose of the dexamethasone to reduce the side effect of the corticoids for this patient. And if dexamethasone with half dose, we will reduce the dose of dexamethasone after 2 weeks, every 2 weeks. Likely protocol, likely SLS 2004 protocol for this patient. And if the patient has severe condition, we will add the etoposide or rituximab if the patient can pay the rituximab first. And so we will have some patients go out because they have the severe flare of the SLS, and we cannot do the transplant for this patient. But until now, we have maybe 10 patients with a genetic mutation can bleed until now with the rituximab and the dexamethasone. But we don't know they can tolerate how many times for this group, because we don't have the transplant in Ho Chi Minh City.
Jorge, any thoughts about how you manage them if you can't get them to transplant?
Yes, yes. I think that are two things for me that are very important in that cases. The first one is the beginning approach with multidisciplinary team. The pediatric palliative care team is very, very important since the diagnosis, because in that time, the patient is with a critical illness that could die. So it's the best way to the family to know that it could happen. Also, if I don't have any curative treatment for that patient, the palliative care could continue. And I can buy some time for the patient and for the family, some things to try to get the bone marrow transplant. But in other words, the palliative care team could help them to transit this difficult way.
Yeah, I think that is really important to do that, to have the team available from palliative care to kind of help if things do not go the way that they need to go, from the get-go. And I also liked how you also brought up the multidisciplinary team, as far as it also seems like it's really helpful in all of these places. If you have someone that has expertise in HLH, you mentioned that earlier, that, having that high degree of suspicion and getting the PICU reaching out, if there's a patient, that they're worried about. And so we didn't quite get to that discussion point. But with that, we're kind of coming up to the end of the hour. And let me see if I can't stop sharing. I wanted to say a special thank you to our panelists that were able to join today, and for sharing with us all of your wisdom, as you've taken care of these patients. Michelle, do you have anything you want to say in closing?
No, just thank you for learning with us. And maybe the one other thing that I would add is that in Asia, we have a WhatsApp group for histiocytic disorders. And I think having time zone friendly people that you can text for the difficult cases can be really helpful. So we'll just put that out there for your regions, so that we can continue to learn from each other. But thank you, everyone. And thank you to the Histiocyte Society for providing space for voices for the rest of us to learn from our colleagues who have a much harder job working in the context they do.
Thank you, panelists. Much appreciated. Thank you, everyone who joined. Have a great day or night.
Thank you very much.
Thank you.